Welcome to you all. Very good morning for the ECG workshop. We covered some
Good
areas
morning.
like understanding the ECG paper, the scale, the intervals, and then the impulse, the different wave patterns. Then we went to look at the leads, the limb leads, and unipolar leads, bipolar leads. Then also we looked at the chest leads, their placement, the importance of keeping them constant always. Then we looked at the simple way of measuring the rate. Then after the rate, we went to the axis determination. We understood the 12 cameras, the left-sided cameras, the inferior cameras, and also the anterior-posterior, the transverse plane cameras and all. Then we have now come to a stage where we will be discussing today about the hypertrophy, atrial and ventricular hypertrophy will be today's topic. So this is the fifth lecture in the series, and we have the sixth lecture on the conduction defects, like bundle branch block, right bundle branch block, left bundle branch block, and all that. Right bundle branch block, left bundle branch block, trifascicular block, and also probably the look at the interatrial atrioventricular conduction defects like AV nodal delays and which type 1, type 2 and all those things. We will see next week. So that finishes the first part of the ECG workshop. Whatever we have looked at plus today's lecture and next part will be the first part. Then we will go into ischemic heart disease, which is the major second part. The third part will be arrhythmias. So wherein there is a conduction disturbances are responsible, some of the arrhythmias, some of the de novo arrhythmias, atrial arrhythmias, ventricular arrhythmias, nodal tachycardias, all those things will form the third part. And the final part will be miscellaneous conditions, electrolyte disturbances and things like that. So at the end of each part, let's say part 1 by Thursday, I'm going to give you a questions. So by then we would have had 6 lectures. Maybe around 6 to 8 questions on each of the lectures, totaling to 40 to 50 questions. Some of them will be even real-time ECGs also. And to the extent we have covered, you will interpret them and post them back to me in my WhatsApp. So that I will give you probably on Thursday itself, I will circulate to you. Friday, Saturday, you take time. By Saturday evening or Sunday, you post. By the time when we come to the next class Tuesday, we will be knowing what answers you made. And anything that is not clear, I can easily understand from your answers that if all of you are doing not correctly, then that area I will explain once again. And the so-called true answers also the key also I will give on next Tuesday. After that, we will enter into the ischemic heart disease. So this is the plan now. The first 6 are comprising in the first part, and the 5th lecture of the 6 is going to be now done. Now, as you know, there are atria and ventricles, right? So there could be hypertrophy of the atria and hypertrophy of the ventricles. Fortunately or unfortunately, we have 4 chambers, so we need to know 2 atrial hypertrophies and 2 ventricular hypertrophies. If I were to be frog, probably we would have learned only 1 ventricular hypertrophy because there are no 2 ventricles. But nonetheless, we have the advantages of having 2 separate ventricles, and we will learn about them, atrial hypertrophy and ventricular hypertrophy. Why it is important? Clinically, we have several conditions which are known to be associated with atrial hypertrophy. The moment you see your ECG itself, you can say probably this fellow is having one of the conditions of atrial hypertrophy. Okay. Now, first of all, we need to understand what waves are produced by the atria. We know that P wave is the product of atrial excitation. This we have already seen. What is P wave? P wave is the beginning of the PQRS complex. It is the upward wave usually in almost all the leads. Okay, and this has got a duration of 0.01 seconds, 0.12 seconds. That is 3 small squares. 0.12 seconds or 3 small squares is the normal duration. What is the vertical height of the P wave? Not more than 3. Not more than 3 millimeters. Each millimeter is 0.1 millivolt, so 0.3 millivolts. Vertically 3, horizontally 3 is the normal P wave. Okay, so we know P wave is due to atrial excitation, atrial depolarization. Atrial depolarization is not seen in the ST segment and the ensuing QRS complex. And the P wave normal characteristics are usually upright in almost all the leads except AVR. Disturbance is there, let me stop. All of you, please mind your mics. Please mute them. Please mute your mics and keep them muted throughout. When the question session comes, then probably we can open. Now, so P wave is almost always upright except in AVR lead. All the 12 leads, it is upright. And it has got a horizontal duration of 0.03 squares, which is the normal P wave duration. PR to PR interval together with the PR segment is about 0.2 seconds. Now, the vertical height of it should not be more than 3 small squares or 3.3 millivolts. Each small square is 0.1 millivolt. So 0.3 millivolts is the vertical size. Now, where do I look at the P waves? P waves are not always seen in all the leads. P waves are best seen where the atria are represented. Atria are represented mostly in the L2 and V1. So for example, if I want to examine P wave, I have to only concentrate on two leads, the L2 lead and the V1 lead. V1 directly being on the atria, the right side of the chest, right sternal border at the fourth interspace, that is right overlaying the atria, so it records. And L2 because the impulse is, atrial impulse is more downward than leftward. Because ventricular impulse is downward and leftward, but atrial impulse is downward. So the best lead to look at is the L2 lead. This is the direction of the L2 lead, right arm and foot, and that direction is the L2 lead. So we have to look at L2 lead. So the rule is P wave should be studied in L2 and V1. So now how it actually looks like normally. You see here you have the RA and LA. So the atrial wave, P wave has got two components. One component is the right atrial component. The other component is the left atrial component. The right atrial component occurs first because the sinoatrial node is in the right atrium. So excitation starts from the right atrium. Right atrium completes the depolarization, merges into the left atrial syncytium and activates. So they appear as almost as one wave, a wave in L2, RA and LA merges. That is what you see on the screen. Whatever you are seeing on the screen is the normal one. Now, the right atrial and left atrial components are not separately seen in L2. And the duration is 3 small squares or 0.12 seconds. Vertically, it is 3 small squares or 0.3 millivolts. Okay. Now, let us look at V1. V1 is oriented here. It is right on the right atrium. So impulse coming towards the lead will register a positive deflection. So RA wave will be positive, and the left atrial impulse is going away from the lead. So naturally left atrial produces a negative deflection. So V1 shows a biphasic P wave. The first component is the right atrial component and the depressed component is the left atrial component. And this is not very pronounced, just a little biphase you will see. Again, the duration is 0.12 seconds. The height is not more than 3 small squares or 0.3 millivolts. So this is the normal P wave. Then we know there is a right atrial hypertrophy and there is a left atrial hypertrophy. So how does it look like in right atrial hypertrophy? The right atrial hypertrophy, the P waves are like arrowheads. This is called the arrowhead P wave, also called the P mitral. Okay, P pulmonale. P pulmonale is the right atrial hypertrophy, pulmonary hypertension, right atrial hypertrophy. Pulmonary veins are connected directly to the right ventricle, right atrium. So right atrial hypertrophy will be there. That is called the P pulmonale, which is the arrowhead P. So very tall. Okay, duration wise, it may not be wide, but length wise, it is more than 3 small squares in L2. So what will be in V1? V1 also, the first component will be accentuated. There are two components in V1, right atrial component and left atrial component. The first component is very much accentuated and tall, but the left component is unaltered because there is no change in the left atrium. Suppose there is biventricular hypertrophy, both the components will be there. Okay. Which condition will have biventricular hypertrophy, biatrial hypertrophy? If there is biatrial hypertrophy, then both components will be prominent. For example, mitral stenosis. Left atrium is enlarged, right atrium is also enlarged. Then you will have both P mitral and P pulmonary. So, okay, that is about the right atrial. And left atrial, the right atrial component is normal, but the left atrial component is now prominent. So much so L2 will become like a bow, like a saddle. You will have two peaks. The first peak is the right atrium and the second peak is the left atrium, and left one being more prominent because of left atrial hypertrophy. Common cause of left atrial hypertrophy is mitral stenosis. Okay. Now, in the V1 lead, how it happens? Right atrial component is normal, just like the other one, the normal one, but the left atrial component is so prominent and it away from the V1 lead, so much so it registers a deep negative deflection. Now, the wave here in V1, it may be more than 3 millimeters down, the left atrial one, and the duration is wider. Whenever there is a left atrial enlargement, duration also is affected. Is that clear? Again, fundamentals I am telling. Atrial hypertrophy, for atrial pattern, we have to look at L2 and V1, no other lead. Normal L2 is RA and LA components are merged and it will produce a smooth upward curve, mostly upright in almost all the leads, except in V1 where it is biphasic. And AVR, of course, it is inverted. And the duration is 3 small squares and vertically also 3 small squares. Whereas when you come to ventricle V1, the both components are separate. V1, RA being directly under the V1, you register a positive right atrial component and a small left atrial component which is going away from the V1. So there will be an upward stroke and a little downward stroke, just as what is seen here, but they are very normal. So when you come to the right atrium and right atrial hypertrophy, there is no increase in the duration, but the amplitude is more than 3 small squares. And the right atrial component is being very prominent. Left atrial component will be in the downward part of it in L2. In V1, the left atrial component will be as like earlier, but the right atrial one will be very tall. This is called the P pulmonal because it is the pulmonary hypertension is the common cause of right atrial hypertrophy. It's also called P pulmonal, other name for it. Whereas the left-sided hypertrophy of the atrium, L2 will show double wave. First wave is of the normal arc right atrium, and then there is an accentuated left wave, which is the LA part. So it will be like a saddle with the two peaks. The central depression will be there. Okay, but here the duration also will be wide because it takes more time to activate right atrium and also bigger left atrium. The duration is prolonged more than 0.1. Again, James is joining. Please mute your mic. James College people, can you hear me? Okay, fine. I think they are okay. So the V1 part is again the first component is the right atrial component is normal, but the left atrial component is very deep and the duration is wide and the amplitude, downward amplitude also may be more than 3 millimeters. This is the basic understanding. Let us go into details of that. Let us see some ECGs. So that is the normal heart, normal atria. So between the two, the right atrium is the anterior chamber and left atrium is the posterior chamber. So right atrium is directly under the V1 lead, left atrium is behind. So this is the normal heart law. Let us see the right atrial enlargement. Okay, where do I look for that? L2 and V1. Look at L2. L2 is very sort of like arrowhead. So L1 you see that is a normal P wave. In L2 the lead is like an arrowhead, and the duration is not wide. You can see it is 3 small squares only. Vertically it is 4 small squares. Okay, amplitude is higher. Actually, if you have a real-time ECG, you can put a magnifying lens and see the height also. Whereas in V1, you see the right atrial component is very prominent, left atrial depression is very mild. This is how it appears in the L2 and V1. This is Netter's drawing. We will see a real-time ECG. So that is what exactly is the right atrial enlargement. The anterior chamber is very much enlarged. The right atrium is the anterior chamber that is enlarged. Okay. Now you see right atrial enlargement. That is the standardization. There you can see 1 mm is equal to 10 millivolts. 1 millivolt is equal to 10 mm, or 0.1 millivolt is the height of each small square. Here this is 4 small squares. Okay, so vertically. Horizontally, it has not crossed 3 small squares. It need not. In right atrial enlargement, it won't. Suppose there is biatrial, you will have the width as well as the height. Both will be seen. Okay, now right atrial enlargement, this is how it looks like. Let us look at an ECG. P wave voltage is 4 boxes or 4 millimeters. So that is the height measurement using your scale. And that is the P wave, which is peaked P wave or arrowhead P wave or P pulmonale. Okay. Always examine lead 2 for right atrial enlargement and V1 for the left atrial, because for atrial enlargement 2 leads, lead 2 and V1. Tall peaked P waves, arrowhead P waves, amplitude 4 millimeters or 0.4 millivolts abnormal. What are immediately on seeing this, clinically you must know what are the conditions which produce right atrial enlargement. Fundamentally, pulmonary hypertension, of course mitral stenosis with the back pressure, tricuspid stenosis, tricuspid regurgitant jet coming into the right atrium, pulmonary valvular stenosis, again the backflow, the back pressure there, and then the pulmonary embolism, atrial septal defect with left to right shunt. Initially, it will be left to right because the left-sided pressure is more, it left to the right shunt is the normal AST initially. But once the right-sided pressures go up, then the right to left shunt will occur. So you have to, these are the few conditions which can cause a right atrial enlargement. The moment I see an arrowhead P wave, is it pulmonary hypertension? Is it mitral stenosis? Is it tricuspid valve stenosis or tricuspid regurgitation or pulmonary stenosis or pulmonary embolism or ASD L2 or shunt? See, by looking at a small information in the ECG in lead 2, you can narrow your diagnosis into these 4 or 5 things if it is there. Okay. Always try to immediately clinically explain why it occurs. Done. Now look at the ECG, left atrial enlargement. Where I have to look for L2 and V1 I have to look for. L2 lead looks very normal. It is not tall. It is not wide. No problem. V1, I can see 2 components very clearly. The second component is more prominent than the first one, and the duration is 4 or 5 squares, which is widened. So widened and then downward component more prominent is left atrial enlargement. So that is left atrium, the posterior chamber. The anterior chamber is the right atrium, posterior chamber is that. So you can say left atrium is so much enlarged in this particular diagram, Netter's diagram. That is why taking more time to activate it, and the negative component is prominent, and the duration also has increased. So this is now looking at the V1. The first component is normal, the right atrial component. The next component is rather very prominent and deep also. The duration also is more. Here you see P wave duration is 4 boxes. 4 boxes is equal to 0.04 into 4, that is 0.16 seconds. Normally P wave should not be more than 0.12 seconds. It is more than 0.12, so it is increased. And also you have to measure the duration like that from the beginning to the end of the P wave. Okay, so that is the left atrial wave, left atrial enlargement with a prominent. So again, the text of it. Always examine V1 and L2 for left atrial enlargement, biphasic P waves, prolonged P waves, P wave greater than 0.12. In this ECG, it is 0.16. Downward component is more prominent. What are the causes of left atrial enlargement? Just like pulmonary hypertension, there systemic hypertension. Just like tricuspid stenosis and tricuspid regurgitation, mitral stenosis and mitral regurgitation. Just like pulmonic stenosis, there aortic stenosis. Aortic regurgitation also, because the jet is so much, left ventricular pressures increase, left atrial pressures also subsequently increase and it dilates. Left ventricular hypertrophy with dysfunction. LVH also produces consequent LAE also. Generally in atria, we don't call hypertrophy. We call as enlargement. This is by convention. Though LAH we won't say. LAE and RAE. Because these are not, muscle thickness will not become more. There is no active reason for the muscle to become thicker because force of contraction is not important, but the chamber has to dilate. So that is dilatation of the chamber leads to enlargement. So left atrial enlargement is characteristically present when you have a V1 and L2 showing a biphasic P wave, prolonged P wave, duration greater than 0.16 seconds. Second component may be prominent and cross 4 millimeters. That also is there. What are the conditions? Systemic hypertension, mitral stenosis, mitral regurgitation. This is called P mitral, in fact. So that is called P pulmonale. This is called P mitral. Aortic stenosis, aortic regurgitation, left ventricular hypertrophy with dysfunction. LV dysfunction is there. So consequently, LA pressures increase, LA dilates, LA enlargement is there. Atrial septal defect with right to left shunt. Hope you have digested both left atrial and right atrial enlargement. Now we show you an ECG. Okay. We'll come to that. At the end of the session, I'll show the ECGs. Then let us enter into ventricular hypertrophy. Just like the atrial hypertrophy, we have ventricular hypertrophies also. Left ventricular hypertrophy, very common. Right ventricular hypertrophy also is very common. So, ventricular hypertrophy, you see the QRS, normal, where you have to look for V1 and V6. So these are the leads directly on the ventricles, V1 lead to V6 lead. They are tapping the potential difference from the chest directly on the ventricles. And V5, V6 are the lateral leads. V3, V4 are the anterior leads. V1, V2 are the septal leads or the right-sided leads. Okay, I look at V1 and V6. Okay, so where is V1? V1 is on the right sternal border in the fourth space. Where is V5? V5 is in the fifth interspace and anterior axillary line. And then V6 is in the fifth interspace, mid axillary line. V4 is at the apex. Okay, now normally the V1 is a downward stroke, S wave is the prominent wave. Okay, and then V6, R wave is the prominent wave. This is a normal pattern. So when they are like that, how do I know whether they are enlarged or not? Then you require a measurement. You see the left atrium, left ventricle is hypertrophied, very red colored, thick one. Naturally, the forces towards the left lead are more. So V6 gives a very tall deflection. And the V1 is away from the V6. So V1 lead records a very deep negative deflection. So the LVH, V1 shows deep S waves and V6 shows tall R waves. Then sum total of them you take and then measure. We'll come to that. Now, in case of right ventricular hypertrophy, you see the arrow here, more forces are going towards the V1. So there is an upward component is there. Normally you don't see upward component in V1. There is an R wave in V1 and we don't see S wave in V6, but here there will be an S wave. So simply speaking, V1 and V1 shows normally S wave and V6 shows normally R wave. That is normal pattern because the direction is towards the left and down. Whereas in left ventricular hypertrophy, the same pattern is maintained but accentuated. V1 deep S wave, V6 tall R wave. And the total should be more than 35. Whatever it is, we will come to that number. Whereas in right ventricular hypertrophy, the V1 lead normally should not have R wave. There is an R wave there. And V6 normally should not have an S wave. There will be some amount of S wave will be there. When you see a positive deflection in V1, it should strike three important things. Only three conditions. If you normally V1 positive deflection, R wave is not seen. If the R by S ratio, that is the R wave divided by S wave is more than 1, which means R wave is taller than the S wave, there are only three conditions. Number one, right ventricular hypertrophy. Number two, posterior myocardial infarction. And probably there is the right bundle branch. Most important, posterior infarction and right ventricular hypertrophy. When the RS ratio in V1 is greater than 1. Normally RS ratio, R is not at all there, almost very small. RS ratio will be nearing sort of 0.1 or something like that. If it is more than 1, it signifies posterior myocardial infarction or right ventricular hypertrophy or right bundle branch. How to differentiate, we will see. Ventricular muscle hypertrophy, QRS voltages have to be looked into in V1 and V6, and of course in L1 and AVL. Why? L1 and AVL are directly on the left ventricle. L1 lead is this one, left-sided lead, and AVL also is the left-sided lead. V5, V6 are on the actually directly on the chest leads. So V1, V6, L1, AVL are the four leads you will look here. We may have to record half standardization. Why? Because the ECG paper can accommodate vertically. ECG paper has got 20 small squares. 121. Let's say ECG paper will have a capacity for 60 or 70 small squares. If the voltage is very high, it will go out of the paper. Then you will reduce the standardization to half so that the waves are compressed and multiplied by 2, you work out. T-wave changes are opposite in direction. This is very important. Whenever there is hypertrophy, the T-wave will be opposite in direction to the QRS. If the QRS is positive in V6, there will be deep T inversion. If the QRS is negative in V1, there will be a tall upright T-wave. Okay, T-wave changes are opposite in QRS. If they are not, then there is a problem. You understand? So the T wave should be in the opposite to the QRS. If it is not, it signifies associated ischemia and infarction. Associated axis shift will be there. Left ventricular hypertrophy will have left axis, and also it may have atrial enlargement or atrial hypertrophy. So the consistent features are T-wave changes are in opposite direction to the QRS, associated axis left or right depending on which ventricle is hypertrophied, and associated atrial enlargement. If it is right ventricular, there will be right atrial, and if it is left ventricular, there could be left atrial enlargement. In mitral stenosis, there will be right ventricular enlargement and left atrial enlargement also. Associated atrial enlargement. Now you see. Right ventricular hypertrophy. Right ventricular muscle is much thicker than the left ventricular muscle. Normally it is the other way around. Normally right ventricular muscle is thinner, left ventricle is around 9-10 millimeters in thickness. That is 3 to 4 millimeters in thickness. You call LVH and the L thickness is more than 10 millimeters. How do I know that? By measuring in the ECG wall thickness of the left ventricle and the right ventricle in the echo. Now here, ECG wise also we can say. So right ventricle is Netter's drawing very clearly shows a hypertrophied right ventricle. Where I have to look for? V1 I have to see, V6 I have to see, L1 I have to see, AVL I have to see, L1 and AVL. Okay. V1 R by S ratio is much higher. R wave is 1 to 2.5, that is 10, 12 millimeters tall. S wave is around 4, 12 by 4. RS ratio is more than 1, that is 3. So I know that RS ratio more than 1, tall R waves in V1 more than S wave. T waves are inverted, they are in the opposite direction. Overall negative voltage in lead 1 is much higher. Right axis deviation is there. Right atrial enlargement also is there. You see the axis here? Already we know axis. The axis there is right meet criteria, you can see. L1 and AVL you take, right meet criteria are satisfied, right axis there. Right atrial enlargement also you can see peak arrowhead P waves in the lead 2. So right atrial enlargement is there, right axis is there, and right ventricular hypertrophy also. Tall R wave in V1, RS ratio much more than S wave. R by S ratio is around 3 there, more than 1. Deep S waves in V4, V5, V6, and DD includes right ventricular hypertrophy, posterior myocardial infarction, anticlockwise rotation of the heart. As I told you, there are 3 important things. One is RVH, the second one is posterior infarction. There may be associated bundle branch block and anticlockwise rotation. Anticlockwise is heart is turning. This is clockwise rotation, this is anti-clockwise. Associated right axis deviation is there, of course. In the ECG, deep T inversions, opposite direction, absence of inferior MI because the T waves are in the opposite direction. You see here, if the T waves were not in the opposite direction, the T waves are also in the same direction as the R wave, then it is posterior infarction. Simply looking at the ECG, you can say whether it is RVH or posterior. When we come to infarction, we'll learn. Now, look at this ECG. First of all, what is the rate of the heart in this? What is the heart rate? 300, 150, 100, around 100, little less than 100, because the complex is falling. Next complex is falling on the third big, bold line. First bold line is 300, second bold line is 150, and the third bold line is 100. So 100 is the heart rate. And what about the axis? Right meet. So L1 is down, L3 is up, L1 and L3 are meeting each other. Right meet criteria, right axis. Is there any right atrium? Yes, there is, because L2 shows a peaked wave, like an arrowhead, like the normal wave. Okay, and then is there right ventricular hypertrophy? Yes, V1 R by S ratio is infinite because there is no S wave at all. Whatever we are receiving is only R wave. Normally, V1 should not have an R wave. Here, R by S, S being 0, V1 R by S is very high, which means that is there is a right ventricular hypertrophy. Look at the T waves. They are definitely opposite to the QRS. That's very important. The T wave should be in the opposite direction, then no infarction. Suppose they are in the same direction, then there is my posterior infarction. Look at the S waves in V6, very deep S waves. Normally, we are not supposed to see S waves in V6. We have a very deep S waves in V6. So the ECG, the rate is around less than 100. And then the axis is right axis. There is a right atrial enlargement. There is a typical right ventricular hypertrophy with associated T inversion in the opposite direction, which tells me that it is a case of right ventricular hypertrophy with right atrial enlargement, right axis deviation, something which is causing all these things. The common causes of right ventricular hypertrophy are mitral stenosis, pulmonary stenosis, pulmonary regurgitation, tricuspid regurgitation, any one of these conditions, or ventricular septal defect with left to right shunt, and all those. We'll come to those things in the next slide. Is there any hypertrophy? Yes, there is, and it is right ventricular hypertrophy. Associated right atrial, associated right axis, heart rate is 100. Tall R wave in V1, R by S is much more than 1. Deep S waves in V4, V5, V6. DD includes right ventricular hypertrophy, posterior infarction, anticlockwise rotation. Associated right axis deviation is there, RAE is there, deep T inversion in V1, V2 in the opposite direction to the R wave, absence of inferior. What are the causes of right ventricular hypertrophy? Long-standing mitral stenosis. When there is long-standing mitral stenosis, left atrial pressure increases and pulmonary capillary pressure increases. The back pressure into the right ventricle, right atrium increases. So right ventricle also increases. So pulmonary hypertension, right ventricular hypertrophy, right atrial enlargement, left atrial enlargement. Left ventricle is not enlarged in meds. Okay. Pulmonary hypertension of any cause, whatever may be the reason, like primary pulmonary hypertension, COPD with pulmonary hypertension, pulmonary embolism with pulmonary hypertension, pulmonary arterial stenosis with pulmonary hypertension, so many causes of pulmonary hypertension. VSD or AST with L2 or shunt, either at the level of atria or at the level of ventricles. If there is a shunt, initially it will be L2 or that produces RVH. Congenital heart disease with right ventricular overload. All conditions, congenital conditions, where right ventricular overload is there. Tricuspid regurgitation, because the regurgitant jet is coming back into the right ventricle and then making it hypertrophied. And pulmonic stenosis, the outflow is obstructed, so right ventricle enlarges. Hypertrophy. So if you see right ventricular hypertrophy on the ECG, you must think of these conditions. Long-standing MS, pulmonary hypertension of any cause, VSD or ASD with L2 or shunt, congenital heart with right ventricular overload, tricuspid regurgitation, pulmonary stenosis. So this is the typical ECG in mitral stenosis. How do I know that? There is a P wave there, which is L2 P wave is very prominent, which tells me there is a right atrial enlargement. And look at V1, the left atrium also is very prominent, deep component of the left atrium, and R by S is very tall, so there is a right ventricular hypertrophy. V6 S wave is very deep, and L1 and L3 they are meeting each other. So right axis is there, right atrium is there, left atrium is there, right ventricle is there, left ventricle is not there. Such a condition is typical of mitral stenosis. Suppose you have added atrial fibrillation, then of course MS with atrial fibrillation. In that case, the P wave changes of hypertrophy will be missed. We will not atrial hypertrophy. When there is atrial fibrillation, make it a point not to comment on atrial hypertrophy. If you say atrial fibrillation and also left atrium enlarged, that means something is wrong in the brain. Isn't it? So when there is atrial fibrillation, we are not able to see an atrial wave. Where is the question of left atrial hypertrophy or right atrial hypertrophy? Never say atrial fibrillation and also atrial involvement. It's not possible. ECG of MS, RVH, RAE. Classical changes, right ventricular hypertrophy, right axis deviation, right bundle branch block also was there in the previous one. I have not told you now, so I'll tell you when we come to that. P pulmonale because of the right atrium, P mitral because of the left atrium. If atrial fibrillation develops, it disappears. Now, we have got one more chamber to look at. Now, the left ventricle is enlarged. Left ventricular muscle is double the size of the septum. Very big. Normal being 10 millimeters. This is 20 millimeters or even more. The axis vector will be very forcefully going leftward because of the thickness of the left ventricle. So all left-sided leads will record a very strong positive wave. Then what are my left-sided cameras? L1, AVL, V5, V6. Look at L1, very tall R wave, and a complement of that L3 is being this side lead, lower, this is the L3 lead, left arm and right hand foot, and it will have a negative deflection. And V1 will have a very deep S wave. Normally itself V1 and S waves will be there, but these are much deeper. V5, V6, very tall R wave. Normally there is R wave prominent, it is double prominent there. Then how do you know it is normal or not? Then I have to measure. So V1S plus V5R. That is S wave in V1 plus R wave in V5 together should be more than 35. Normally there will be less than 30. What is here? 1, 2, 3, almost 15, 16, 17 millimeters is the S wave, and V5 or V6, whichever you take, V6, 1, 2, 3, 4, 25 or 27. So when let's say 25 and 17, 25 and 15 itself is 40, 42, 43, which crossed 35. So there is left ventricular hypertrophy. Evidence of left ventricular hypertrophy. Again, the rule, the T wave will be opposite in direction. Look at V1, the T wave is upright. The deep S wave followed by upright. Look at V5, V6, tall R wave, T wave is opposite. If they are not, then it says there is an ischemia and infarction. So accompanying T wave changes are essential to say whether it is the T inversion is due to LV strain and LV. You say LV strain. It's not actually LV strain. It is a manifestation of left ventricular hypertrophy itself. The T inversions there are not ischemic T inversion. They are the manifestations of left ventricular hypertrophy. They're the other way around. Both are up or both are down. Then there is associated ischemic heart disease. Okay. Now what is the axis here? Left leaf, L1 is going up, L3 is coming down. So there is left axis deviation. What is the atria? Can I see any right atrium? Not much. Can I see a left atrium? Very much, because the lower component is very deep. Left atrium is there. And V1S plus V5 or V1S plus V6R is equal to more than 35. Or you can take L1 and AVL also. So L1 you see 1, 2, 3, 15. More than 11 millimeters, 13 millimeters there, or more than 11 in AVL also suggest left ventricular hypertrophy. There are several criteria for left ventricular hypertrophy. The commonest one is simple one, V1S plus V5 or V6R is more than 35. T waves in the opposite direction, associated left axis, associated left atrium, confirm your diagnosis. Even if they are not there, if this much is good enough, there is also LBB here. When we come to that, we will see that. High voltage QRS in the limb leads, R wave in lead 1 plus S wave in lead 3, that also you can see. R wave in lead 1, you see the R wave in lead 1 plus S wave in lead 3. R wave in lead 1 is 1, 2, 3, 15 millimeters. This also 1, 2, 3, 13, 14 millimeters. 29, 15 plus 14, 29. But my cutoff is 25. So R wave in lead 1 and S wave in lead 3 is more than 25. S in lead 1, R in B5 more than 35. AVL more than 11. Any one of these criteria. Okay. Or forget about other things, males, females. Simple. S wave in V1 and R wave in V5 or V6. That criteria is satisfied more than 35. L1R plus L3S more than 25. That is also satisfied. And then you have the QRS duration also prolonged, which tells that there is a partial left bundle branch block. We will come to that. Associated left axis deviation, as of course you can see the left axis deviation very much because left leaf there and also left atrial hypertrophy in the form of deep second component of the P wave in V1. Associated, these are called the Cornell's voltage criteria. There are two criteria internationally followed. Cornell's criteria are Estes point scoring. Any one of them we can follow. Normally we follow the Cornell's voltage criteria. Okay, point scoring is they give points for each of these and then add the points, and a little cumbersome, a little beyond this particular lecture. Now, look at this ECG. Whenever you look at the ECG, first thing is, are the RR intervals constant? Yes, they appear very constant. Then I can say about the rate. What is the heart rate? So take here any complex which is falling on the deeper line, and from there you count. The second component complex in the V1 is exactly on the darker line. So next one, you see the next darker line, 300, 300, 150, 100, 75, a little more than 75, maybe around 80 is the heart rate. Okay. Now, what is the axis here? Right mate or left leaf or normal? All are not upright. L1 is up and L3 is down, which means there is left leaf criteria. Left axis is there. How about atrium? Right atrium, I can't see anything in V1. In very small P wave, I don't see anything in L2, so no problem. And V1, you see the deeper component is much higher, much prominent, so the duration also is wider. So there is a left atrial enlargement, and also look for the criteria of LBH. L1R plus L3S. L1R is how many? 1, 2, 3, 4, maybe 20, 25. And this is even more than that. Even one wave itself is 25. Combination should be more than 25. Already that criteria is satisfied. V1S plus V5R. V1S 1, 2, 3, 4, 20. 4 big squares, 20. Here 1, 2, 3, 4, 5, 6. 30 plus 20, 50. My cutoff is 35. So there is a voltage criteria satisfied. Look at the T waves. T waves are opposite in direction to the main QRS. Okay. It is a little tricky whether the associated ischemia are not there. So many criteria are there. But fundamentally, let us understand hypertrophy. In this lecture, when we come to a combinations, we will see later on. So we have now looked at right atrial, right ventricular, left ventricular. What are the causes of left ventricular hypertrophy? Two types: pressure overload, volume overload. Volume overload is dilatation, pressure overload is muscle hypertrophy. Pressure overload occurs in systemic hypertension because of the higher pressure in the aorta. It has to pump forcibly, so hypertrophy. Or when the aortic valve is stenosed, against the stenotic valve, ventricle has to contract with greater force. There will be pressure overload. Okay, two important conditions: aortic stenosis and commonly hypertension, systemic hypertension, are the causes of pressure overload. Volume overload means not much thickness of the muscle. There is some thickness of the muscle, but more it has become, chamber has become more dilated. Commonest are aortic agitation, blood coming back to accommodate ventricle dilates. MR, from the mitral valve, the jet is coming down, either from the mitral valve or from the aortic valve, or dilated cardiomyopathy. Obstructive cardiomyopathy, pressure overload. Dilated cardiomyopathy, volume overload. Ventricular septal defect, by both right and left ventricular volume overload will be there in ventricular septal defect. Because when there is a VST, initially there will be a flow from left to right, and then all the blood that has gone to the right ventricle. Causes of LVH: pressure overload, systemic hypertension, aortic stenosis, volume overload, aortic agitation, and mitral regurgitation. Okay? And then dilated cardiomyopathy. Then ventricular septal defect, both right and left ventricular volume will be overload. Hypertrophic cardiomyopathies, hypertrophic obstructive cardiomyopathy, there will be pressure overload. Without hemodynamic increase in pressure, volume overload occurs. When there is a pressure overload is there. And athlete's heart, a person who is a very hard working sportsman, there will be some amount of left ventricular hypertrophy. That's athlete's heart. Normally, this is called physiological cause of left ventricular hypertrophy. Now, let us look at whether can we differentiate from the ECG whether it is volume overload or pressure overload. So this is the left ventricular hypertrophy ECG. All of you know this ECG very easily. You can say the first thing is what is the rate. So I see here, this is the one which is falling on the larger, darker line. So 300, 150, 100, 75. So it's around 80 or 82 is my heart rate. What is my axis? Axis is left leaf. Okay. Is there any right atrium? No. Is there any left atrium? Yes. The duration is 4 squares here and the downward component is prominent. So I have an ECG with normal rate, with left axis, no right atrium, left atrium, and left ventricle. I have to see L1 plus L3. I have to total this being 1, 2, 3, 4, 20, and this itself is 30. 30 plus 20, 50. Normally it should not be more than 25. So voltage criteria there is, limb lead criteria satisfied. Coming to the chest lead, 1, 2, 3, 4, 22 is the 22 or 23 is the S wave. Normally we see S wave here, but this is 23 coupled with 1, 2, 3, 4, 5, 6. 6 is 30, 30 plus 23, 53. If it crosses 35, these two, V1S plus V6R is LVH. Look at the associated T wave in abnormalities, STT changes, which are in the opposite direction. Here they are in the same direction. So here also they are in the opposite direction. Here also they are in the opposite direction. This is classical of left ventricular hypertrophy. So this ECG has got normal heart rate, left axis deviation, no right atrium, left atrium present, left ventricular hypertrophy. Whenever you see like this, then there is hypertrophy. This is called the pressure overload. We will see that. See here. 1, 2, 3, 4, 20. 1, 2, 3, 50 and 35. Just borderline. Almost appears to be. If you take V5 sometimes, it's 1, 2, 3. This is near 20. 20 and this is another 20. 4 square. So if this is not satisfied V6, you look at V5 and it is satisfying. Now the T wave is opposite in the direction to the main QRS complex. Here opposite in direction. Whenever it is down, the T wave is up. Here also it is down, T wave is up. Here T wave is R wave is tall, and then T wave is down. Here R wave T wave. So this sort of arrangement is what is called the pressure overload. And we already looked at the causes of pressure overload. And look here. Typical, very typical LVH. 1, 2, 3, 4, 5, 5.5. So 26, 27. And here, 1, 2, 3, 4, 20. 27 plus 20, 47. If you take V5, it is even higher. So there is definite left ventricular hypertrophy. And look at the T waves. This is opposite. This is opposite. This is opposite. All the first 3 leads are opposite, but the other leads are on the same side. And the T wave here, a very tall peak T wave. This suggests there is volume overload. Right-sided leads will not show that, but the left-sided leads from V3, V4, V5, V6, they register a very tall T wave, which is in the same direction as the R wave, peaked arrowhead-like T waves, not wide and no depression, no inversion like here. Here they are inverted and depressed, and that is not seen. Such a picture is what is called the volume overload. Okay. So we understood left ventricular types, pressure overload like in hypertension, IHD, LV strain pattern we call ST depressed T inversion, V5, V6, L1, AVL have to be seen. And then volume overload, like in mitral and aortic agitation, prominent positive T waves in V5, V6, and also in L1 and AV. So that ends today's this one. Then we have to look at the not ischemia straight away, but we will look at the bundle branch blocks. So after the bundle branch blocks, we will go for the ischemia. So by now we have completed several things. So the scales, the ECG paper, the intervals, different wave patterns, their connection with the cardiac impulse, and then we have the different sizes of the waves in terms of duration, in terms of the height. Then we looked at the rate, simple method we used. Then we also looked at the axis, left me, right meet, left leave criteria. And then the leads to be looked at are all the four L1, L2, L3, and AVF are the leads to be looked into. Then we discussed today about the atrial hypertrophy. Our focus is on L2 and V1. And how about the components there? Right atrial, P pulmonale, left atrial, P mitral, how they occur. Then the left ventricular and right ventricular hypertrophy first, and the left ventricular hypertrophy, and the volume overload and the pressure overload. So next time I will do the conduction defects, including bundle branch blocks. That completes part 1. Then we'll have a small exam-like thing, so-called self-assessment for you. I would have given you around 50 questions, including some 10 ECGs, 40 one-word answers, and then some 10 ECGs to look at, and just comment on 1 or 2 aspects on that, not the whole ECG. So ECG report writing is important. At the end, I will show you what is the chronological way of ECG report writing. By now, you already know that first important thing is the standardization. 10 millivolts is equal to 10 mm is equal to 1 millivolt. Is there or not, you see. Then you comment on the RR intervals constant or not. Then you say sinus rhythm, because every P wave is followed by the QRS, and T waves are PQRST is seen, SR. Then you calculate the rate. After the rate, you say the axis. Then you say atrial hypertrophy, right, left, or both. Then ventricular hypertrophy, right, left, or both. Pressure or volume overload. Then comes the conduction defects. Then go for the infarction and arrhythmias. This is the sequence we will follow. If there are any doubts, I am prepared to clear now. By Thursday, I will give you the question paper. Around 40 one-word answers questions, multiple choice, and 10 ECGs. So real-time ECGs, I will give you as a PDF file. So ECGs, you just comment on the ECG 1, 2, 3, I'll number. What is the answer for 1, what is the answer for 2, like that you can write.
Good morning, sir.
Good morning, sir. Tell me.
Okay, sir. You have given everything in a very good clarity, sir. And easily understandable way you have explained the hypertrophy. I was feeling when I was student, I should have a teacher like you. I should have a teacher, but unfortunately did not have. We had to read through the Goldberger textbook and have to struggle to understand.
Very difficult, sir. Very difficult to understand. Those are very complicated. This is very simple way of going for a clinician. How we are not going to become electrophysiologists. All the same, we want to use a simple tool to interpret what is going on directly at the bedside, and then come to some reasonable conclusion and investigations, and of course, management.
Thank you, sir.
Thank you for giving the opportunity. And this quiz will put them in the right perspective. The 50 questions in first part, again 50 in the second part, maybe around 5 or so in the third part. And that will give them an idea to answer. And I request all the PGs, not only first years, second years, and final years also, to answer the quiz and then give it to me, and I will evaluate them and pass it on to Sudhir Garu, not to individually say whether Deepa has done well or Srilekha has done well, or Sriram compare with others. That is not the idea. Whether you have learned the concept. As a group, did we move forward? That is the idea. And I'm going to do that on Thursday. after the Thursday's lecture, when the first part will be over. And we will discuss those answers in next Tuesday. Next Thursday onwards, we'll go to the ischemic heart disease part.
Okay, sir. Thank you.
So
Thank you,
shall
sir.
I end the call for everyone?
Yes, sir. One thing I wanted to ask.
Please tell.
So that axis deviation, we did just like how we discussed today, LAE, RAE, LVH, RVH, all the why the causes and the importance.
Yeah.
The axis deviation, the what are all the
I will.
causes or the importance to give? We have
These are in my
that
mind.
point alone. We are not.
These are in my mind. Instead of
Okay.
staying in left axis, right
Okay.
axis zone, we will also plot on an ECG, looking at an ECG, all the 12
Okay.
will take,
All.
pinpoint
Yeah.
what exactly is the axis. I will show how to do it.
Exactly. Axis.
Also, the rate
Okay.
calculations of saying 100 or more like that, we will exactly know how much is the heart rate also I will show. These two things I will
The
show.
heart rate as well.
Also,
Okay.
the causes of the axis, left axis deviation and right axis deviation. I will do that.
Okay.
Those slides are there. I will include them and show here.
Okay.
So three things I will do. How to exactly say the rate, is it 92, 72, 84, that one. And also exactly
that is-
say what is the axis. And also what are the causes of axis deviation,
Axis.
right and left. I will give. Good idea.
Okay.
Include them.
Thank you.
They are in a comprehensive presentation. This is a simpler presentation. So
Simple question. Okay.
and put them here. So
Sure, sir.
depending on the level of the audience, some such
Correct.
slides are not in.
Correct.
But I
Okay,
think
sir.
it is essential because these are PG students and that information will be very useful. Also, you will not only look at the QRS axis, you should be able to look at the P axis also sometimes. Very important. How to look at the P axis, how to look at the QRS axis. T axis may not be that very important, but P axis and QRS both, if they are divergent, then there is a problem. Because P axis and QRS should go in the same direction. They're not
Direction.
going in the same direction. Then we are in some problem. So that also I will.